Hello everyone, myself Dr. Dinesh Kumar Bagga, Professor and Head Department of Orthodontics, School of Dental Sciences, Sharda University, Greater Noida, Uttar Pradesh. Today I'll be discussing about diagnostic accuracy measures, sensitivity, specificity, and predictive values. So we'll be discussing about the measures which are required to test the diagnostic accuracy. And these are the test characteristics, sensitivity, specificity, and predictive values. And predictive value can be positive predictive value and negative predictive value. As you know, the diagnostic tests are to discriminate between the diseased and non-diseased. So a perfect diagnostic test is supposed to give positive results for the diseased individuals and negative test results for the non-diseased individuals. So every time if you are getting positive test result in diseased and negative test results in non-disease, that is a perfect diagnostic test. But the problem is sometimes we get the opposite result. It might be erroneous results in some of the individuals tested. That is, some of the non-diseased individuals might show positive test results, while some of the diseased individuals might show negative test results. So that kind of error we have to take care. So that is very important, that we must know about the accuracy of a particular diagnostic test, that how much it can discriminate, how better it can discriminate between diseased and non-diseased. Therefore, the diagnostic accuracy of the newly available diagnostic test has to be validated by comparing it to a gold standard, which represents the best of the existing tests, but it is not practiced in routine due to it being often invasive or expensive, whatever the reason, but that is not much used. So other tests we can compare with them to know that how much it has the power to discriminate between the diseased and non-diseased. Now, diagnostic test accuracy can be interpreted by understanding the test characteristics, sensitivity, specificity, positive predictive value, and negative predictive value. Now, sensitivity is about true positive rate. The ability of a test to correctly identify with those with the disease. Whoever are diseased, that need to be identified. And that is the power of the test, the sensitivity, that how many true positive it can identify. True positive means the people are diseased and they get positive result. So it reflects the probability that the diagnostic test will be positive among those who are diseased. So if 100 diseased people are tested positive, all patches positive, that means sensitivity is 100%. But it is not the case. In all the tests, there must be some erroneous results also. So if we say 80% sensitivity means if 100 diseased people are tested, only 80 will get positive result, and that is true positive. And 20 out of 100 will not get positive. They are diseased, they should get positive result, but by error they are getting negative result. So we call it false negative, because they are actually not negative. By error they are getting the negative result. Actually they should be positive. So false negative are also diseased. Now we can calculate the sensitivity, the number of individuals having disease and showing positive test results, that is true positive, out of all the diseased persons. Number of actually diseased individuals, including true positive who are correctly identified, and also those who could not be identified but diseased, they are false negative. So true positive out of true positive and false negative, that is the sensitivity. So we can say the individuals having the disease and identified as true positive out of all the diseased individuals, whether true positive or false negative. Now, same way, if we talk about specificity is about true negative rate. It is the ability of the test to correctly identify those without the disease, and it reflects the probability that the diagnostic test will be negative among those who are non-diseased. So specificity is about the number of individuals not having disease and showing negative test result, that means true negative, out of all the non-diseased individuals. That means including true negative who we have correctly identified, but those also, they are non-diseased, but by error they have been labeled as diseased, that is false positive. So by error they are getting positive. Actually they are non-diseased, they should get negative result, so they are false positive. So we can say the specificity is about the number of individuals not having disease and showing negative result, true negative, out of all the non-diseased individuals. That means true negative as well as false positive. So specificity is true negative out of the true negative and false positive people. A clinician and a patient show concern about a different question. What is the chance that a person with a positive test result actually has the disease? And how likely is a person with a negative test actually has no disease? That is indicated by predictive values. Their sensitivity and specificity, respectively, they are telling about true positive and true negative out of the diseased or non-diseased, respectively. But here, positive predictive value is the probability that a positive test result will correctly indicate disease among those with positive test result. So here also, just like sensitivity, we check true positive, but out of all the positively tested. It is not about all diseased, it is about all the positively tested. All the positively tested means whether they are true positive or false positive. So it is the proportion of actually diseased individuals showing positive test result, that is true positive, among all positively tested individuals, including both true positive, those who get positive result correctly, and false positive. False positive are actually non-disease. So here we are talking about positive test results. Among all positives, how many positive people are actually diseased? So true positive out of true positive and false positive. Same way, negative predictive value is also the probability of getting the negative result, which is correctly identifying non-disease people among those with negative test result. All the negative tests, whether it is true negative or false negative, how many true negative we have identified. So it is the proportion of actually non-diseased individuals showing negative test results, that is true negative, among all negatively tested individuals, that is true negative as well as false negative. So true negative out of all the negatively tested individuals, true negative and false negative. Now, if we compare sensitivity as well as positive predictive value, we see sensitivity is correctly identifying diseased, and positive predictive value is also about correctly identifying disease, that is true positive. So we are talking about true positive. But in sensitivity, we are checking the correctly identifying disease, that is true positive, among all actually diseased individuals, that is true positive, and false negative, who should be tested positively, but by error they are getting negative result, they are also diseased. But in positive predictive value, we are concerned about all positively tested people. So correctly identifying disease, that is true positive, among those with positive test results, whether it is true positive or false positive. So we can say among all positively tested, how many are true positive out of all positively tested. So here we can see that sensitivity is about true positive out of true positive and false negative, whereas positive predictive value is about true positive out of true positive and false positive. So that difference we have to remember. Now, specificity versus negative predictive value. Specificity is correctly identifying non-diseased, and negative predictive value is also about correctly identifying non-diseased. But the difference is that the specificity is correctly identifying non-diseased, that is true negative, among actually non-diseased individuals. Actually non-diseased individuals means those who are negatively tested correctly, true negative, and those also non-diseased which have not been correctly diagnosed by getting the negative result. By error they have got positive result, that means false positive. So identifying the non-diseased true negative out of true negative and false positive. But in negative predictive value is about identifying the non-disease, that is true negative, among those with negative test results, whether it is true negative or false negative. So that is the difference. If you see the denominator, there is a difference in denominator. In specificity, true negative out of true negative and false positive, and in negative predictive value NPV, it is true negative out of true negative and false negative. Sensitivity and specificity are characteristics of the test and do not depend on the disease prevalence at all. They indicate the extent to which the test is able to measure what it is supposed to measure. So they represent the power of a diagnostic test to discriminate between those with and without disease. Sensitivity and specificity can be considered fixed characteristics of a diagnostic test, as the prevalence of the disease has no influence on sensitivity and specificity. For a test to be accurate, both sensitivity and specificity should be high. So it is a fixed characteristic because there is no influence on sensitivity, and prevalence has no influence on sensitivity and specificity. So we can say they are fixed characteristics. But when we talk about PPV, NPV, these predictive values, they depend on the prevalence. So later we'll be talking about that. Now, sensitivity and specificity of a test have limited clinical usefulness of disease likelihood in an individual patient when there is an epidemic. Clinicians are chiefly concerned with the predictive value of the test rather than its sensitivity and specificity for measuring diagnostic accuracy. But we must remember a crucial point is that the prevalence of disease in the population affects the predictive value of any test. This means that the same diagnostic test will have a different predictive values according to the prevalence of the disease in the population in which it is being applied. So we must know about the prevalence when we are talking about predictive value. Now, just see this table, how the tests are conducted, what is the test result, and how disease is identified. Now, when you see the first row, the positive test result, if you get in the diseased, that is a true result, A, that is true positive, that is given by the dark color. And when you, in non-diseased, you get the positive result, that is false positive, B. And when you make the total of all the positive, you check how many true positive out of all the positive. And in the end of the first row, you can get the positive predictive value, that is true positive out of true and negative, true positive and false positive. Sorry. So same way, second row, you can see the negative test result. When the disease is there and you get negative test result, it becomes false negative. And next you see if negative test result for those people non-diseased, you get the true result, that is true negative. So both the negatives means C plus D, and in the end you see your negative predictive value, that is true negative out of all the negatives, true as well as false negatives. So these are about predictive values. And if you come to the column, you can see the disease people are A plus C. That means whether they are true positive or false negative. That means they should be positive, but they are getting negative result because of the error. So true positive and false negative, they are making diseased people. And you can calculate the sensitivity, the true positive out of false negative as well as true positive. True positive as well as false negative. Same way, in another column where non-diseased people, if you see test result, you can get true negative as well as false positive. And the non-diseased people are those who are true negative and also those who are incorrectly got the positive result, but they are non-diseased, false positive. And out of these non-diseased, how many are true negative? So true negative divided by true negative as well as false positive. So you get the specificity. And total population, if you want to calculate, A plus B plus C plus D, that is uh, true positive, false negative, and true negative. If you calculate, you get the total population. And prevalence can be calculated. The diseased people, that means A plus C, diseased people, true positive as well as false negative, those who should be positive, but with error we are getting negative, but they are diseased. So diseased people out of total population, and we get the prevalence. Here I have explained this prevalence of the diseased population out of total population, that is true positive plus false negative out of entire population. And then sensitivity, you can see the true positive out of all the disease, that means true positive as well as false negative. Specificity is about negative true negative rate, probability of a negative test result among those without a target disease. You can check this, that the true negative out of true negative as well as false positive, because false positive is also non-disease. When we talk about predictive value, positive predictive value is true positive out of all the positive, true plus false positive. And same way, negative predictive value is true negative out of all negatives, that means false negative as well as true negative. Diagnostic accuracy or percent agreement we can calculate by getting whatever correctly identified. Correctly identified are true positive and true negative out of total population. So true positive plus true negative out of total population. Now here I'll be discussing about an example. Now just check in the first row that positive test result. First of all, let me tell you that total population we have taken 1000 and the prevalence is 10%. If total population is 1000 and prevalence is 10%, that means the diseased people are 10% is 100. You can see the total third row in starting, diseased people are 100. Now we have sensitivity. In the first column, you can see sensitivity 90% and specificity also we have assumed 90%. Now sensitivity is 90%. That means out of 100 diseased, we will be getting true positive as 90, but in 10 people, we will not get positive result. We'll get negative result by error, that is false negative. So that is about the first column. And second column, if you check about specificity, it is 90% negativity, 90% specificity, means true negative will be getting 90% of all the non-diseased. Now in 1000 population, non-diseased are 900, because 100 are diseased and 900 are non-diseased. And out of 900, when we check, because it is 90% specificity, so out of 900, only we are able to get the true positive, true negative 90%, that is 810, and 10% will be false positive. True negative will be 90% and false positive will be 10%. So out of 900, 90% are 810 true negative and 90 will be false positive. So when we complete this contingency table, now we can calculate. In the first row, you can see that the positively tested people are actually 90 plus 90 is equal to 180. And out of that 180, true positive is 90 only. So 90 out of 180, that means 50% positive predictive value is there. In second row, if we see negative test result, we see that 10 people are false negative and 810 are true negative. So total negative test results are basically 820, and out of 820 negatively tested, true negative are 810. That means 98.8% negative predictive values there. When prevalence is 10%. Now here we can see that prevalence is 10%. Here I've already explained that 100 out of 1000 people are diseased population. Sensitivity we have calculated. Sensitivity we have assumed 90%. That means 90 true positive out of true positive and false negative. You can see 90%. Specificity is about the true negative out of true negative as well as false positive, 90%. Positive predictive value, we have calculated the true positive of all the positives, 90 out of 180, 50%. And negative predictive value, that means true negative out of all the negative test results. That means 810 out of 820, 98.8%, which has been explained. And percent positive agreement, diagnostic accuracy, we can see that true positive and true negative out of total population, that is also 90%, because true positive we have 90 and true negative we have 810, total 900 out of entire population 1000, so it becomes 90%. This has been explained in this table. We can check again. The true positive are 90 and false positive are 90, and false negative are 10 and true negative are 810. So with that we can calculate predictive values as well as predictive values when we have this, and that is based on the sensitivity and specificity and the prevalence. Now, the impact on positive predictive value as prevalence changes for a test with 90% sensitivity and 90% specificity. So we have assumed that sensitivity and specificity are 90% and prevalence is 10%. We have already calculated. Here I wish to inform you about the impact of the prevalence. Now, if you check the middle row first, what we have already calculated in 1000 population, in 1000 population, 10% is the prevalence. So we have 100 diseased, rest 900 are non-diseased, and here true positive, we have calculated it to be 90 because it is 90%. We can calculate. We can based on sensitivity. 90% can be identified as true positive. So out of 100, it will be 90. And then false positive, we can calculate out of not diseased. That means not diseased will be identified, 90% will be identified as true negative, but false positive will be 10%. So 10% of the 900 non-diseased will be 90. And ultimately, total positive on the test, 90 plus 90 will be 180, and positive predictive value will be 90 out of the all the positive test results, 180, that we have calculated 50%. Now, if you see the prevalence on the left side, 1%, and right side, about 20%, how it changes. In the end, if you see PPV, it becomes 8%. That means out of 100, only 8 people will be showing true positive if the prevalence is 1%. If the prevalence is 20%, it becomes 69%. That means out of 100 positive test results, 69 are showing true positive. Let me calculate out of 1%. If you see 1000 population, uh, just 1% are diseased. That means 10 people. And out of 10, and that means not diseased are 990. And out of this diseased, 90%, that means 9 people are true positive. When we calculate false positive, we calculate from the non-diseased, and non-diseased are 990. 90% will be correctly identified true negative, but 10% will be identified as false positive. So 10% of 990 will be 99, and this uh, total positive will be the 99 plus 9 will be 108. Total positive will be 108. So out of this 108, true positive is just 9. 9 out of 108 means it is 8%. Same way, if you check that 20% prevalence, that means in 1000 people, 200 are diseased, 800 are not diseased. And out of 200, 90% will be correctly identified. That means 180 will be correctly identified. And out of not diseased, 90% will be true negative, but 10% will be false positive. So 10% of false positive out of 800, and that will be 80 false positive. So 180 plus 80 will be all positives, total of 260. And this out of 260 total positive, we can say that true positive is 180. So 180 out of 260, that is 69%. So we can see that how the prevalence is affecting. If prevalence is increasing, PPV is more reliable. So predictive values change with the prevalence of target disease in contrast to sensitivity and specificity, because sensitivity and specificity are not going to be affected by the prevalence. So as the prevalence of a disease increases, PPV will increase while NPV will decrease. On decrease of prevalence, PPV will decrease while NPV will increase. In a high prevalence setting, it is more likely that persons who test positive truly have disease, and the number of false positive test results is decreased as compared to the low prevalence of the disease. So it is more reliable in high prevalence setting. It is important to understand that predictive values of the two populations can only be compared if the disease prevalence is the same in both the populations. Now, in the end, I would like to make some comments that the diagnostic test accuracy must be determined while interpreting diagnostic test results for appropriate clinical implications, as a test result may be a true positive, true negative, false positive, or false negative. Sensitivity and specificity are the fixed characteristics of the diagnostic test, as they do not depend on the prevalence. Predictive values are more relevant than sensitivity and specificity when people are being screened, but the researchers should provide information about prevalence of the disease or event, as it is a determinant of the predictive value to make appropriate interpretation of screening test results. Thank you so much for patient hearing. Thank you once again.